Welcome to our panel, The Future of Transplantation and Living Donation. Organ transplant is very important in our healthcare system. There are about 2,800 organ transplants in Canada each year, 1,700 kidneys, 550 livers, and then a few other things like hearts. But there's also about 4,400 people on the wait list. We can never meet the demand for organs, and that's especially true again of kidneys and livers. There are about 24,000 Canadians on dialysis waiting for a kidney. In 2018, the latest full statistic we have, there were 762 deceased donors and 555 living donors. Again, they donated a kidney or a lobe of a liver. Interestingly, about 2/3 of deceased donors are men and 2/3 of living donors are women. More than half of living donor recipients are unrelated to the transplant recipient. There's a lot of generous Canadians out there. And the number of deceased donors has increased a lot in recent years, and the number of living donors is climbing too, but a little more slowly. So to discuss some of these big issues and living donation in particular, we've assembled a really all-star panel, and I'm going to ask each of them to introduce themselves, and I'm going to ask some questions, and we'll take some questions from the audience on Slido. I already have a couple of questions come in that I'll incorporate, but I'll start by asking the panelists to introduce themselves. And one little note, I'm going to refer to the panelists by their first name so we have an informal conversation. I don't mean to be insulting to our doctors, but we just want to make it informal. So maybe Atul, you can start by introducing yourself and then we'll go around the panel.
Yeah, hi, I'm Atul Humer and I'm the head of the transplant program here at the Toronto General Hospital.
Catherine?
Hi there, my name is Catherine Tinkham. I'm a transplant nephrologist here at UHN. I'm the director of the HLA lab, which is where all the organ matching is done. And I'm the chair of the Kidney Transplant Advisory Committee for Canadian Blood Services.
And Nazia?
Hi, I'm Nazia Selzner. I'm a transplant hepatologist here at TGH, Multi-Organ Transplant Program. And I'm also the medical director of the live donor liver transplant program.
Great, and Blaine, welcome.
Good morning. My name is Blaine Amir Syed. I am a liver transplant surgeon at Toronto General and Sick Kids, and I'm the surgical lead for pediatric liver transplant at Sick Kids.
Okay. And Sunita?
Good morning. My name is Sunita Singh. I'm the medical director of the UHN Living Kidney Donation Program and also transplant nephrologist here. I'm also the vice chair of the Living Donor Advisory Committee with Canadian Blood Services.
Okay. Jason?
Hi, everyone. I'm Jason Lee, one of the urologists here at Toronto General Hospital, also one of the kidney transplant surgeons.
Okay. And Gonzalo up in the corner, I didn't forget you.
Good morning. I'm Gonzalo Sabiduti, one of the transplant surgeons and liver surgeons here at UHN.
Great. So as you see, we have a fabulous panel of people who know more about transplant than probably anyone else in the world. So we're going to take advantage of that knowledge. Now, Atul, I want to start with you with a very general question. Give us a sense, how is Canada doing in organ transplant overall? How do we compare in the world? How are we doing generally?
Well, there's quite variable deceased donor rates across the country, but there has been a lot of success in the last decade where many jurisdictions have seen an increase in the number of deceased donor and living donors. Given that, though, there's still this huge unmet need, and it basically means that many of our patients are waiting years and years for a transplant, or even worse, some people are waiting so long that their health deteriorates, and some people do pass away on the waiting list.
Yeah, so there's a chronic shortage. Is that a solvable problem? I mean, we're going to talk about some of the solutions, but overall, is it solvable?
I think it is solvable. A big part of that solution is the reason we're here today, and that's living donation, but also, increasing deceased donor activity, increasing utilization of organs. These are all kind of pieces of the puzzle that can help us really solve this problem.
Now, Catherine, the living donation program is relatively new. Tell us why it started and why at UHN.
So living donation at UHN is actually not that new. It's been going on for a number of decades, but the Center for Living Donation is a relatively new center. Just like Atul said, we are not going to solve the organ shortage for many patients without using living donation and really optimizing its use. This center is to elevate the profile of living donation in the public space, in everyone's conversation, to ensure that we deliver education, eliminate a lot of the myths around living donation, and importantly, to enhance the experience of patients and donors as they move through living donation, looking at quality outcomes and the best possible experience.
Now, we have a very mixed audience. We have some real specialists, but we have just some families, people who don't know a lot about this. So, Catherine, tell me, some people are surprised that we can do living donations. You know, you can take away one of my organs and I'll still be fine. Explain how this works a little bit.
So when we think about living donation, the reality is that we've actually are considering the outcomes of two patients. We've got recipients who need an organ and donors who are able, if they're appropriately healthy, if they've passed numerous screening tests, really, really excellent healthy donors, are able to donate a part of their liver or one of their kidneys with anticipated excellent outcomes over the course of their lives. We wouldn't be able to do this unless that were true, but it is a very real possible solution for many people in need of an organ transplant.
And is it risky?
So no surgical procedure is without risk. I think we all need to accept that. But as living donation becomes more and more common, those surgical risks with experience are very minimal. And importantly, there is enormous attention paid to the workup of potential living liver and kidney donors to make sure they are in the best possible health, which minimizes any potential risk for ongoing complications.
Now, Nazia, you do a lot with living donation. What would you say to someone who's considering this, who has a family member who needs a kidney, needs a liver? What would you tell them to think about?
Well, we would advise them that in terms of the living donation, the outcome survival is equal, if not better, than the deceased donation. Certainly for the liver, we have long-term outcome now after doing this for almost 20 years. Exactly 20 years is when the living donor program has started at TGH. And our outcome at short-term and long-term is excellent, is better than deceased donation. Part of it is, as Catherine mentioned, is because we are using donors that are healthy, they are young, and we make every effort to not jeopardize the life of any donor. So these are excellent liver that are used for transplantation.
Now, not everyone's a match, right? You have to match. It matters. Blood type, things like that matter. And
absolutely.
Yeah. So how do you figure out if you can say I want to give my kidney to my brother? How do I know I'm compatible, if it's good for him?
So I think that's a me question.
Okay.
So a couple of things that we look at. So first of all, this is assuming that someone has been cleared medically to be a donor. So the first thing we look at is blood group. Now, blood group is always easier if they're compatible, but if they're not, there are options in order to make sure that someone can still achieve living donation. And then we actually look at whether or not the donor and the recipient are matched at the immunologic level. Is the recipient likely to reject the donor? And that's the testing that we do in the HLA laboratory. We do extensive testing on the donor and the recipient to look at that degree of compatibility. Importantly, not every living donor who's medically suitable is going to be a match for their recipient. So that's where we need to look at other options, including list exchange, desensitization, or kidney paired donation. But what I'd like to believe is that if we have a healthy living donor who wants to donate, we hopefully will be able to facilitate a living donor for a recipient, either from their intended donor or from another donor within the system.
Okay. And Sunita, you work with living donors a lot, kidney donors. I mentioned an example of giving to my brother, but there are people who give anonymously, right? Just out of generosity.
That's exactly right. A donor can be donating to anyone. It could be a partner, a spouse, a sibling, a friend, but it can be a stranger. And we have numerous incredible people who donate their kidney to someone that they don't know because they want to help. And in fact, we often think of donation helping one individual directly, but our anonymous donors, or what we also call non-directed donors, can often be critical people in triggering chains of transplants in the kidney pair donation program, often triggering many, many transplants that otherwise would not have happened. So not only are they helping, an individual, but they're also helping numerous people.
Now, we heard a little bit about this earlier in the conference, but it's kind of a domino effect, right? I give a kidney and then somebody else. Give me a little example, if you could, of how it works.
That's exactly right. So you could have you can have a donor who wants to give to the recipient, but they're not compatible. Another donor who wishes to give to their recipient and they're not compatible. And you can have an exchange, but also if you have numerous pairs like that, where you can't find a compatibility, often that anonymous donor will trigger a compatible transplant, which will then trigger another donor to donate to somebody else and to somebody else and to somebody else, and eventually to somebody on the waiting list. So numerous people receive transplants, as well as people being removed from the deceased donor waiting list.
And Jason, as someone who does transplants, I'm interested, I gave some figures at the outset about kidneys, but why do so many people need kidneys?
Well, I think, unfortunately, with rising rates of obesity, metabolic diseases such as diabetes, high blood pressure, and there are genetic conditions that predispose patients to renal failure. So these rates for these metabolic diseases are on the rise. We know obesity is an epidemic, particularly in North America, but other places around the globe. So these are all different causes of renal failure. And there's, not to say I'm drumming up my own business, but there are other surgical causes for renal failure as well. Patients may have kidney trauma, kidney cancers that require surgeons to remove kidneys. And so these can also lead to patients requiring kidney transplants, or at the very least starting dialysis and then considering transplant down the road.
But isn't dialysis good enough? Do people really need a transplant?
Well, I guess from a kidney perspective, we are lucky that there is something like dialysis. Some of the other liver physicians and surgeons here will speak to this, but there's no dialysis for liver failure, unfortunately. So, it's a good, backup plan, but we do know patients who are on dialysis don't do as well as patients who have had kidney transplants, whether it's living donors who donated kidney to them or whether they received a deceased donor kidney. Depending on which area of the country and what data you look at, but the mortality rate of patients on dialysis is sort of quite high, scarily so. We know that for patients individually, but also society at large, transplantation is a significant benefit.
And there's an economic benefit too. Dialysis is very expensive. It's hard on the person's life to do dialysis 3 times a week.
Sure. I mean, the economic health system impact of living donation is immense. It keeps patients off dialysis, and the cost of that is immense. And so it can save our healthcare system quite a lot of money. And luckily, most of the time, these kidney transplants go very well. And so we really need to push the envelope on increasing the number of donors, whether it's living or deceased.
Now, Gonzalo, you work in the cancer field. People might be surprised to learn that you can actually do transplants to treat cancer. Can you tell us about that, the circumstances?
Yeah, I mean, my whole practice is both, as you mentioned, on removing cancers for patients that have, either primary cancers or secondary metastasized tumors to their liver. And I think, people really don't know that, the main risk factor to develop primary liver cancer, what we call hepatocellular carcinoma, is actually inflammation and cirrhosis of the liver. So it's a conundrum of patients that have liver disease and need a liver transplant because their liver is not working. But more importantly, that inflammation, produces tumors. And the only treatment, for those tumors is actually a liver transplant. So in fact, in our list, around 40 or 50% of the transplants we are performing, liver transplants we're performing, are actually in patients with liver cancer. And interestingly, the outcomes are very good after liver transplantation for this kind of disease.
And do these patients, do they still get their chemo radiation, but they also get a transplant?
Yeah, so in most instances, these patients, when they need, they will get treatments before they get the transplant. So yes, they can get chemotherapy directly to their tumor, or radiation, as you were mentioning. And then that's mainly to control the tumor. Those treatments are not curative. So what we do is we control those tumors while the patients are waiting. And then transplant is one actually going to make a difference in them and actually are going to cure these patients with a low recurrence rate or relapse of the cancer after the transplant.
Wow. Now, Blaine, you work with children. We sometimes forget children get transplants as well. Can you tell us a little bit why? I imagine a lot fewer transplants for children, but why do they need transplants?
So the numbers are fewer for sure, but it's still a significant amount of patients that we transplant. So on a yearly basis here at Sick Kids, with donors being done at Toronto General, the living donors done, we do on average 30 to 35 liver transplants. The majority of these children have basically congenital defects of their bile duct or liver system. That's probably around 60%. We, as Gonzalo mentioned, also transplant kids for tumors, which is not uncommon. And then there's other inherited or developed diseases of the liver or metabolic diseases for which we transplant children. And in all of these cases, it would be curative.
Now, I imagine if you're a parent of a child who needs a transplant, you probably desperately want to give them part of your organ. Is it always parents who donate living donations?
It's most commonly parents, although it's certainly not always. We have a significant number, as you mentioned before, of anonymous donors within Canada, and that's something that's been very important for the health of our kids and the success of our transplant program at Sick Kids and at Toronto General. We've had family members, friends, we've had people identified on public postings on Facebook who have stepped forward, and some really remarkable people who have stepped forward to become donors for these children.
Yeah, again, earlier in the conference, there were some really touching stories about some of these donors, and some of which went to children. Quite amazing people who do these gestures.
It truly is. And if actually I follow up on one thing that Sunita said before, the other thing that we don't think about from a mental health perspective is, despite going through a real operation, the donors almost, it's not 100%, nothing ever is, but the vast majority say they would do it over again. It's really had a significant positive impact on their lives. It's given it more meaning. And I think that we sometimes underplay that. It's hard to make a direct contribution to somebody's life in our world. And for our donors, they can save someone's life literally. And it has a huge positive impact on their lives as well.
Yeah, it's hard to imagine something more altruistic than literally giving a part of yourself. Nazia, I see you want to jump in there.
Yes, I just also wanted to build on what Blaine was saying, that the satisfaction of helping someone is so immense and so intense that we had actually donor that started by giving a liver and then moved on to give a kidney or vice versa, just because this feeling of helping somebody has fulfilled their life.
Wow. And I want to come back to these access issues and how people decide. But before I do that, I want to go back to Catherine, and I want to address the elephant in the room, because we're all living with this pandemic, with COVID. And I'm interested to know, how did the pandemic affect transplantations? Did you have to stop, or you considered sort of, crucial surgery, or did you have to stop like everyone else? How did it affect the program?
My trick stopped working. So there was activity that absolutely had to ramp down. I think there's a recognition that certainly for many patients, transplant is immediately life-saving in the very short term. So we're thinking about patients needing lung transplant, heart transplant, liver transplant. But for kidney transplantation, where we do have the benefit of dialysis, many of those patients, would be safer in the early days of the pandemic, where we didn't have as much information about the safety of giving immune suppression in the midst of a prevalent pandemic. It was a safer option to actually, pause on some of those transplants. But we have essentially returned to normal now. Even for kidney transplant, for people who are very difficult to match, we wouldn't want them to miss their only option or only offer. So the transplants to those patients continued through as well. Dr. Humar is also an infectious disease doc and can certainly speak more about the impact of COVID on transplant in general.
Yeah, and Atul, has there been an impact, say, on donors? Are donors reluctant? Are there fewer donors in these circumstances?
Yeah, so certainly when this all started, there was a pretty significant drop in both deceased donors and in living donors. And part of the reason is that everyone was scared and frightened, and we didn't want to, even us as physicians, we didn't want to take a chance and expose our living donors to getting COVID within the hospital system. And we were also scared that our recipients, because they have to go on anti-rejection drugs after transplant, which really suppresses their immune system, we didn't want them getting COVID after transplant and having poor outcomes. And since then, we've learned a lot more. We've developed pathways to screen all our donors, both living and deceased, for COVID prior to donation. We screen all our recipients prior to transplantation. We've developed pathways in the hospital that ensure that there's very limited risk of exposure to COVID. And we've developed care pathways post-transplant that advise patients how to mitigate that risk and make sure they stay safe after the transplantation. So as Catherine said, we've now pretty much returned to normal activity, despite there being ongoing COVID activity in the community.
Great. And with a 1 hour panel, this is probably the longest any of you have gone without wearing a mask. So this must be a nice change of pace for you to be here à face découverte, as we say in French.
That's true.
Now, Sunita, I mentioned a minute ago access. So access is not always great. Racialized communities, people with lower income, they don't always know about living donation. They maybe have some concerns, some fears that don't exist with wealthier, more educated patients. How do we deal with those access issues?
Yeah, I mean, that's a great point, and something we've been focusing on all week about access and equity and reducing the disparity to access to living donor kidney transplantation. We know that certain ethnic groups are disproportionately affected by kidney disease in general. So the burden of kidney disease is higher amongst South Asians, Black Canadians, East Asians, and Indigenous populations. We also know that lower socioeconomic status plays a role, and that there's more kidney disease amongst those with lower socioeconomic status. But we also know specifically with living donation that those who are of those ethnic minorities have lower probability of actually getting a transplant, specifically a living donor kidney transplant. And donors of those ethnic groups also have a lower probability of actually getting to donation. So a big part of, obviously there is a lot of heterogeneity within a particular group, but some of the common themes that keep coming up as why this is happening could be, one, a mistrust of the system, two, some differences in terms of knowledge about living donation and kind of awareness of living donation and the potential benefits, stigma and shame in certain communities about sharing that you have kidney disease and you need a transplant are part of the things that we're seeing. And, a big part of it is in terms of increasing the access is really understanding those barriers, working with people in those communities in order to try to improve access by improving awareness and breaking down kind of the misconceptions that exist.
Now, Jason, Toronto's a very multicultural city. Canada's a pretty multicultural country. How do you address those different fears, those different perceptions of organ donation and organ recipients?
Well, I think it's incumbent on us in the physician and healthcare field to sort of develop programs to really foster educating patients and their loved ones and sort of enlightening them on these issues. And especially more so now than ever, the issue of equitable access to healthcare and to some of these programs, we're really realizing that we may not have done as good of a job as we could have or we should have. And so I think we are really putting a lot of effort into marginalized communities and educating them, going out into the community. It's not, it shouldn't be, the onus shouldn't be on patients to go look up something that they don't even know what questions to ask. And so it's incumbent on us to get out there, educate patients, and ultimately it will improve everyone's outcome. Right? I mean, by educating people with kidney disease, liver disease, and teaching them about the programs they have access to, it will help everyone on the waiting list overall.
Now, Nazia, we've talked about inequities in economic inequities, racial, but there's also some gender inequities. There's big differences between women and men in terms of receiving organs and giving donors. Can you talk a bit about those gender differences?
Yes, there are certainly some degree of gender differences, but in a bigger picture, more than just the gender, it's basically the size and the size of the person, the recipient, because the allocation of the organ, particularly for the liver, is based on a score, MELD score, that take into consideration creatinine and as one of the parameters. That's the measure of kidney function. And that measurement could be different, could be affected by the size, and that could potentially disadvantage smaller people, and that could be a smaller man or a smaller female in terms of access to organs. But also same thing true in terms of some diseases where the score is not reflecting how truly they are sick, this patient, and their score remain constantly low, even though they desperately need a transplant to get better. And that's where, you know, this score disadvantages females, but also other causes such as etiology of the disease and size of the person who is need a transplant.
Okay, Catherine, I see you want to weigh in there.
Yeah, so when we're thinking about this in the kidney context, it's really important to remember that the immune matching that you asked about earlier is critical. We know that if the donor and the recipient are not matched at the immune system level, the allograft is going to be rejected a lot sooner. You will not get the maximum lifespan out of that kidney. The biggest contribution to having a difficult time finding an immunologically matched kidney is being previously exposed to tissue that's not your own. So how does that happen? Transplant, blood transfusion, and pregnancy. Pregnancy is a uniquely women's health issue. So when we actually look at women who've been pregnant, we know that up to 75% of them actually make antibodies or have an immune reaction to foreign tissue. And many of them actually have quite a strong immune reaction to the foreign tissue that they would have exposure to in the fetus. And even 30, 40 years later, when they need a transplant, that immune reaction persists and makes it harder to find a donor. It's a very specific access issue also related to women.
So women who've had a pregnancy, is it also more difficult for them to be donors or no?
No, it does not impact donation.
Okay, great. And women, you know, we heard women some have smaller livers, for example, they often make donations to children for that reason. Is that right?
No, I don't think that we can say really that women have smaller size of the liver and therefore they would be a donor for children. The size of the liver is not necessarily reflecting the size of a person, and that's why in order to be a live donor for liver, we have to make exact measurement of the liver for every single donor that's come forward to make sure that they have enough volume of the liver regardless of what's their size. When it comes to children, obviously they require a smaller amount of graft to function. And therefore, majority of the children, at least the younger one, require only the left lobe of the liver, which is smaller version of the graft. And that's where, you know, women, men, everybody can give that portion because it's a smaller portion.
Okay. So when you have a non-expert being the moderator, you get questions that are wrong. So thank you for correcting me. Now, Atul, I want to ask you, people often wonder, with all the people waiting for organs, how do you decide? How do you decide who gets it first? How's that decision made?
Yeah, that's a very important question. So it's a little different for deceased donor versus living donor. So deceased donor, there's a waiting list for each organ, and each organ actually does it slightly differently. So for kidney, for example, much of that waiting list is based on how long you've been waiting for a kidney. Whereas for liver, it's primarily based on how sick you are, with the most urgent, sickest patients going to the top of the list. Now for living donor, you know, there is actually no list, right? So if you have an identified living donor, you can go get your transplant pretty much right away once the donor is cleared and the recipient's cleared. So that's one of the main reasons why living donation is such an attractive option, because you're not getting sicker and sicker while you're waiting on the waiting list.
Now, is that fair? Is that fair that if I have somebody, I could talk somebody into giving me part of their liver, that I can jump to the top of the list? Is that fair?
Yeah, it's totally fair, because one is that you're not really jumping any list because there is no list for living donation. And two is by getting that living donor liver, you're removing yourself from the waiting list for deceased donation. So you're actually benefiting the rest of the deceased donor list. So it's a huge win-win both ways.
Now, Blaine, we know children can benefit a lot from donation because they have a whole normal lifespan because of this. Do they get dibs as a result? Do we give them priority for getting organs?
Yeah, so I mean, I think actually this goes to the previous question about underserved communities as a whole. And I think we have a system that allows for trying to rank people in order of their illness. And on the liver side, that's really about the severity of their illness. The system isn't perfect. And so there are groups, women, underrepresented minorities, and certainly kids that we kind of struggle to figure out how to do this. We do prioritize children in a different way. And certainly if we're thinking about the expected good from any organ, a child over a whole lifetime versus a 60 or 7-year-old adult would have some. But we want to make things relatively equal. And I think that is where potentially living donation, like Atul mentioned, allows us to level that playing field a bit more. I'll tell you, here it's fairly remarkable. In the US, the bigger programs, Texas Children's, Stanford, they may only do 1 or 2 living donors in their pediatric transplant program per year. 60% of our children are transplanted with living donors at Toronto General or at Sick Kids. And so that's really in North America quite remarkable. And it's our way of leveling the playing field, because if not, we wouldn't have access to the organs to transplant these kids.
And Gonzalo, I want to ask you that as well. Do people with cancer, do they get some kind of priority for access to organs?
Yeah, thanks. So definitely, one of the issues is, as was mentioned before, in the liver transplant setting, basically patients are prioritized of how sick their liver is. And many of these patients with cancer, actually, the liver is sick, but it's not as sick as others. But obviously, there's a high risk that while they're waiting, their tumor progresses in a way, especially if it spreads outside of the liver. Over time, we're talking about transplant for cancer. We're talking about cancer confined to the liver. So if they have to wait a long time, these tumors can spread. So I think there's certainly a huge advantage for living donation, because if you have a donor, you're not going to have to wait that time. And we've already shown at many other centers that this really benefits for your health, because the risk of spreading is lower. And yes, in the deceased donor organ list, we try and match them somehow on how their liver, how their tumors are progressing or not, to be able to prioritize them in a way, always taking into consideration that they get equal access to the patients that have end-stage liver disease. So the answer is yes, they get prioritized.
Now, Sunita, I want to ask you a bit, we'll get into more of the ethics of this a bit. How do you ensure that people are giving willingly, that they're not being pressured by a loved one or by whoever? How do you ensure that?
That's a great point. A central principle of donation is that the donor is proceeding out of goodwill, that they want to help someone and they're not being pressured or coerced in any way. And so central to the evaluation process is psychosocial assessments by our social workers and psychiatrists as needed, to really examine all of those facets of donation, the family structure, and the motivation behind the donation, to ensure that this is free of coercion. So that's a big part of our evaluation process, and for us to be sure of that before we move forward with donation. And that really is because we want to put safety of the donor front and center. That's always been a principle in our program, and it always will be. And a big part of that is ensuring that somebody is doing this willingly, that they have autonomy, and that this is their free choice.
Now, you can be doing something willingly, though, but be doing it out of guilt because it's your loved one, it's your spouse or whatever. How do you make that difficult distinction?
Yeah, it's not always easy to peel away of what is really driving someone to donate. I think ultimately what we want to do when we're evaluating people is to kind of tease away the part of, someone may feel guilty, but underpinning all of that, is this coming from a true desire to really want to help someone? And that's what we do with the evaluation process, is we're looking at how much is a reasonable amount of risk to take to help someone that you love. And it's not always easy to do that. And you make a great point, but that's why we have experts within our team from both psychiatry and social work to help us kind of really do a deep dive into people's motivation.
And Blaine, I imagine those decisions are doubly difficult with pediatric cases. Parents would do anything for their kids. They'd give them their heart if they could, right? So how do you tease that out and make sure they're doing the right thing, they're not harming themselves as well?
Sure. I mean, as mentioned, from a medical standpoint, every potential donor has a fairly thorough workup. I think the issues that we run into, to be quite frank, are some of the ones that you alluded to in your previous question to Atul, and whether or not it's fair and equity. You know, we may have parents who are single parents who want to donate to their child and they have other children. How do you provide childcare? We may have parents who, the other parent's working and they're the primary caregiver in that regard for the child who's going to be sick. And it's not net negative or not net equal. It costs money. You have to be off of work. And so it is hard. We do have some challenges. And there's been a lot of work within the living donor community globally and in North America as well to think about how we can better incentivize and equitize the living donor operation so that really people can step forward when they want to.
And Atul, I want to talk a bit about that, about how do we incent people to donate, but they don't have financial penalties, you know, because they miss work, because they have to pay for their drugs. There's a lot of hidden costs there for a donor, right?
Yeah, it can certainly be very, very challenging for some people to undergo the process of organ donation because it does result in some financial loss to go through that process. And there are programs in place through the government that refund certain aspects of this, but they do fall short, to be honest with you. And we here in our program have to some extent relied on philanthropic donations to set up pools of money that can sometimes help these donors. But again, it's not enough. So I think approaching this at a societal and governmental level to really remove any disincentives whatsoever to living donation and simplify and make the procedure as easy as possible for these amazing people who donate a kidney or liver, I think would be really beneficial.
Yeah, it seems crazy to have to depend on charity to help people out who've made such a gift, such a profound gift.
I agree.
Now, Catherine, what do you think we should be doing to incentivize more? Is it just about money, or is there other stuff that we have to do?
So I think when we think about incentives, I'd actually rather think about it as removal of disincentives. And what we really want to do is when we think about the enormous impact that living donation has, not only on the recipient, but also on the rest of our healthcare system particularly in terms of reduced cost. I think what we want to do is make sure that the impact of donation is neutral for living donors. And that's going to look different for different people. So this, I think, also speaks, when we speak about personalized or individualized medicine, we're going to have to think about how we personalize and individualize the circumstances and the systems around living donation to make sure that what they are doing, their donation, has minimal to zero negative impact on them. And I think that's going to be highly individualized in all circumstances, and we need to be comfortable with that degree of variation. I'm just going to go over to Sunita for her thoughts on that as well, since she sees the majority of donors at our center.
Yeah, I would agree that a big part of when we think of incentives, I agree, it's removal of disincentives. And one of the things that we know is that donors on average have about, over $3,000 of out-of-pocket costs whenever they go forward with donation. And we also have a system, as Atul mentioned, in place, which is a reimbursement program. But many Canadians, particularly in the era of COVID, may not even actually be able to upfront pay for those costs, waiting for a reimbursement. So the system is not perfect and can be certainly improved. And when you think of the annual costs of being on dialysis, it's depending on the modality, between $50,000 and $100,000 per year to be on dialysis. So to remit and to repay lost wages for donation is just a drop in the bucket as compared to the huge cost of keeping a patient on dialysis for per year. We know that living donors kidney transplant lasts a long time. The median lifespan, is between 17 and 19 years for a living donor kidney transplant. And so the financial case here is clear of how removing those disincentives can help.
But we reimburse some expenses and do it through philanthropy. But what about the next step? Some countries, people can literally buy organs. Do we worry about that slippery slope that we hear ethicists talk about?
Yeah, we're always concerned when it comes to financial incentives. The reason that this is so controversial in the community is that we fear that potentially those at the lowest socioeconomic status may be coerced or be vulnerable to be being coerced. And so that's something that we want to avoid. There are certain ways potentially to incentivize without direct financial benefit, for example, tax credits, tax benefit. Those have been discussed as potential ways to try to ensure that we're not, as you say, heading down that slippery slope where people are potentially at risk or vulnerable.
And Nazia, another touchy one is celebrities, people with a high profile who make pleas, or even ordinary people who make Facebook pleas. How do you juggle those? People have, the famous case of the Ottawa Senators owner who made a public plea. He got tons of offers. How do you handle the ethics of that?
Yes, that's a good question. So each time a celebrity or non-celebrity actually makes a media appeal, it raises hundreds and hundreds referral to the center, to our program for assessment. Some of these donors are straightforward, some are not. Those that we think are straightforward are selected, but the biggest selection is in terms of why do they come forward as anonymous donor and what's their purpose to do this donation. And that's why they will meet not just one time, but several times with every member of our live donor program, in addition to the psych and social worker, to really try to understand what is the reason behind this donation. But also I must point out that each time a celebrity or non-celebrity has gone to the media, it has raised a potential number of anonymous donors that are willing to give to someone else on the list. Let's say they came forward for Mr. X or Miss Y, and that person eventually got their transplant and moved on. But they would want to continue because they heard about this process. They understand that there are other people on need on the waiting list who are dying, particularly for the liver as they die and they don't have access to dialysis, and they are willing to donate to someone else, either an adult or a kid. So there is a benefit in both sides. The most important thing is for us to understand what is the exact motivation for donating to this particular media appeal.
So we media people, we're not always bad when we cover these stories. We like those stories. Now, Catherine, I see you want to jump in there.
Yep, so I just wanted to say that, when we think about public appeal for living donation, one of the reasons that initiatives like the Center for Living Donation are so important, when we elevate the conversation about living donation in the public space in general, we are in effect making a public appeal for living donors on behalf of everybody who needs them. So it's another way of equalizing the playing field.
Now, Jason, as a clinician, when your patients are desperate, you sometimes nudge them and say, maybe a Facebook appeal would be a good thing. Is that, do you think about that as a physician?
I mean, for sure. I mean, we advocate on behalf of the recipients to pursue any avenues. But I think one thing, specifically for living donors, I mean, I think all of us would be clear in stating that, when a living donor is being evaluated, our priorities, we don't necessarily think about the recipient and the benefits. We try to keep that separate and make sure we have the donor's best interests at heart. And so there's times where donors come forward and they desperately want to donate to their child, but overall, they're just deemed not a good candidate. We don't want to put them at risk. So we do advocate for recipients or people with end-stage organ disease to pursue any kind of outlet they can, but it's there is we don't want to coerce anyone either, for sure.
And Blaine, I want to ask you the same thing, especially with parents. Do you urge them to get out there, because it's always more heartbreaking, it's more touching, a child's story? Do you urge them to get out there and tell their stories?
We do. Whenever we have patients who are referred to us for potential transplant, we urge them to consider living donation, and we guide them to our living donor site for anybody, family, friends, or otherwise who's interested in donating. And, to Nazia's point about, public cases, celebrities or otherwise, transplant occupies a very unique space in medicine and in terms of both deceased donor and living donor. Deceased donor, Josh Mesrich, a surgeon from Wisconsin, just wrote that interesting book about when death becomes life. It's a very unique concept. It's not, there's nothing like it in medicine. And similarly, from a living donor perspective, we generally don't put healthy people in harm's way for any reason, but living donation is one of those things, despite being that safe. And so public perception about transplant is incredibly important. Without public buy-in, we couldn't do what we do, which is quite unique in medicine.
Now, Atul, as Blaine mentioned, transplants like nothing else. There's such a human connection there. Often the donors and the recipients want to connect. Now, there's some ethics involved there. How do you juggle that? This willingness to, you know, they literally share parts of their body. They want to connect, but it's not necessarily a good thing.
Yeah, so it's a very interesting area. I mean, and you know, there's varying practices across different centers on this. Our own practice, and we have a big psychosocial team that's involved and really invested in this and actually actively doing research on this whole area. But our own practice is that, you know, if there is an anonymous donor who subsequently after transplant does wish to be in contact with the recipient and the recipient wishes the same thing, we do allow it. We you know, we don't go out of our way to facilitate it, but we certainly allow it. And we have had many instances where that's happened, and it's been very touching. And the donor and the recipient have actually developed this bond, which is like a blood bond. It's like a family bond that lasts for years and years, and is very rewarding to both the donor and the recipient.
Yeah, those stories can be very touching when we write about them in the media. But what's the potential downside? Why don't you just do it routinely?
So, you know, there are donors who want to remain anonymous. They don't want to be involved in the outcome of the recipient. They're afraid that the recipient could have a poor outcome, or they're afraid that, you know, there may be some coercion and expectation down the line. And same with the recipient side. You know, many of our donors who have chosen to remain anonymous have said that, well, they did it because of altruism. They wanted to help somebody, and they don't want the donor to feel the recipient to feel obligated after transplant that they owe them something.
Now, Gonzalo, I want to ask another sort of ethical question about, you know, these are not trivial surgeries. These are pretty important surgeries. Is there an obligation to do follow-up to make sure everyone's doing okay, especially an altruistic donor?
Mm-hmm. Yeah, absolutely. I think you're making a good point. I mean, we do this very safely, and all the donors, as has been mentioned before, are, you know, they go through a very, you know, a lot of screening, and they're all healthy individuals, but it's a very big operation in both sides, both in the liver and the kidney side. And absolutely, I mean, we see the patients, you know, obviously we take very good care of them. In general, you know, kidney donors stay in the hospital for, you know, a couple of days, liver donors stay in the hospital for around a week. And then we follow them in clinic. We make sure the blood work is correct, and we actually do some MRIs and imaging to make sure that everything is okay. Down the road, usually they go back to have a totally normal life, but they keep in touch with the program if there's any issues down the road, at least from the liver side. Obviously, you know, we haven't been doing this for 100 years to know what happens, you know, in 60, 70 years, at least on the liver side, and we'll have to follow them and see if there's any long-term consequences. But in general, all these patients or all these donors go to absolutely normal and go back to perfect health.
Now, Catherine, I was reading something about advanced donations, paying it forward. Can you explain that concept a bit?
Sure. So advanced donation is something that has been, I would say, trialed or initiated at some of the kidney paired donation programs in the US currently. It's not currently yet codified, or we haven't developed policies in Canada. But this is the idea where someone anticipates that someone in their community, family member, friend, someone they might need a transplant in the future, but doesn't need it now. And they want to actually make their donation now. And there might be a lot of good reasons to do that. They might have time constraints as to when they can, you know, pause work and go and be a donor. They might anticipate that they would be too old to be a living donor at the time that this person might need a transplant. So this might be particularly true for children. And so there are now, I would say still early days, but strategies for those individuals to donate now into a paired donation program. And when their intended recipient does need a transplant in the future, that recipient will be slotted in to receive a transplant from that same paired donation program at the point where it becomes necessary. So why does that matter? It matters because if we wait to try to have those people donate later, we might lose some of those living donors. They may not be healthy enough to donate. It may not be a good time for them. So the idea is that we donate when they donate when it's best for them, and their recipient then receives when it's best or necessary for them. We don't yet have this available within the paired donation system in Canada, but it's an important conversation that is starting. And it's particularly important because this conversation is starting from donors and recipients. It's not just transplant programs that are thinking this is a great way to increase living donation. These are donors and recipients that have access to the same media and the same stories that we all do, who are coming to us saying, this is something we're interested in. And when they tell us those things, it's something we should listen to and explore.
Now, Catherine, while I have you, I'm going to ask you a question. I'm going to read it because it's a very technical question and I don't understand it, but you will. So these are questions that are coming in on Slido as we're talking. So this question is, please explain the need for standardization of HLA lab testing. Does this mean testing across provinces varies? And if so, will it impact province matching?
Wow, that's a really technical question and one that really gets me really excited because it's my favorite topic. So the answer is absolutely, we should have standardized HLA testing. HLA testing is the testing that determines the immunologic match between donors and recipients. You want to be absolutely certain that if you're tested in Vancouver or Winnipeg or Toronto or Newfoundland, that you're not going to have a barrier to transplant because the immunologic results vary. We've actually put a huge amount of work in Canada since 2009 through a national HLA advisory committee where we have worked incredibly hard to make sure that the testing standards, what we're testing and how we test are really aligned, and that you can be confident that when we predict a match anywhere in the country, that match will be valid anywhere else in the country. That is foundational to our kidney paired donation program success.
Great. Even I understood that. But when I saw Provence, I got excited about food in France, but that had nothing to do with that.
I think they probably meant province.
Oh, yes. I guess
autocorrect. Yeah,
I
probably not.
It said Provence, but I guess it was one of these autocorrect things.
Yeah.
Now, Jason, another question coming in, I'll ask you. Someone's asking, do you use robotics when you do transplant surgery?
Yeah, so as a robotic surgeon myself, I'm obviously will declare that as a potential bias, but robotics has come a long way over the last 5 to 10 years, and we apply it for a lot of different surgeries. Kidney transplantation is quite a complex procedure. Robotics has not yet been widely used for kidney transplantation, at least in Canada. There are other sites in Europe and in the US that have used robotics for kidney transplantation. And this is both on the donor side and on the recipient side. I think on the donor side, we already have a minimally invasive way to do that surgery. So the advantages of robotics may not be as great. On the recipient side, doing a robotic kidney transplant is quite challenging, and there's a lot of complex reconstruction required. So it's not widely available. There's also the economic cost of robotics in Canada. But it's something that actually we are looking at carefully at UHN. And just because something's a nice new fancy toy doesn't mean it's better for everyone. And so we're doing our due diligence to look at who might benefit most from robotics. How are we going to fund this kind of program? So not yet being done in Canada, but definitely something that we are, as healthcare providers, looking at and seeing where we can apply that new technology.
And you mentioned the cost. Another little quirk of Medicare is part of those tools are not covered. They're usually covered philanthropically as well. Another oddity of Canadian healthcare. That's what you were alluding to.
Yes, exactly. I mean, we're lucky at UHN to have an amazing group in the foundation, the philanthropy that funds a lot of our research, but also some of our clinical care is wonderful. It allows our patients to have access to things that, speaking of equity, may not be available in some other hospitals or other sites. So we are lucky. Our patients are lucky. We hope to get to a point where things are a bit more sustainable. But definitely we right now are relying on generous donors to fund a lot of these advanced innovations.
Great. So I want to spend the next few minutes that we have before we have to wrap up talking about the future. So where's living donation going to go? Is it going to overtake deceased donation? What's the future look like? Nazia, I'll start with you.
Well, I think that as long as we have that on our waiting list, at least for the liver, which is somewhere around 30% each year, living donation needs to go forward. Obviously, there is risk. So in an ideal world, we would like to avoid having living donation, but that won't happen. The benefit of live donor, as I mentioned, is that they are great liver, they are healthy liver, and their outcomes in terms of the recipient is superior to deceased donation, even when we look at the longer term outcome. The question is, how are we able to bring it up and how we can bring this to more outside to people to know about the benefit of living donation and the benefit that many recipients would get from having that opportunity. So yes, the answer is yes. I believe it's going to be the future. We are trying all strategies possible to make it more, to have more people aware of this and help them to proceed whenever they come forward.
Now, Sunita, if you had a magic wand, how would you improve living donation, the equity, the simplicity, the whole package?
Yeah, so one of the things that we do as part of our assessment is that we look at donors, we look at their health status now, and we also try to predict what's going to happen to them in the future to determine how safe it is for them. We know that we're looking here to minimize the risk to our donors, and we're looking to take acceptable risks, which we take every day in everyday life. But one of the ways, if I had a magic wand, was that I could predict with much more certainty who is going to be 100% safe and who is potentially at risk. Right now, because safety for our donors is so important, if we are in a zone where we're not sure of the potential health of a person in the future, we decline them for donation because it's right now in their best interest. It's the safest approach. But if I had a magic wand, I'd be able to have tools available to me using the data which we're accumulating at the moment to be able to precisely estimate people's risks moving forward and to be able to really make decisions based on that, on who should proceed and who shouldn't.
Now, you talk about risk, but we have to remind people that this is a very safe surgery. The risks are very low for both the donor and the recipient.
That's absolutely right. As Catherine mentioned, this is not a zero risk procedure. There's risk for any surgery, but it is a very, very low risk procedure. That's why we do it. And part of our assessment program is to approve people where the risk is exceptionally low. So where the risk is acceptable also to take to help someone in need. So we are looking at very, very low risks over the short term and the long term when we're selecting donors to proceed.
Now, Blaine, if you look to the future, how could a donation, transplant be better for children going forward? What would be your dream scenario?
Well, I think the nice thing about medicine is you can look worldwide, and certainly in countries, particularly in Asian countries, living donation is the standard of care. In fact, 90% of liver transplant, for instance, if we're talking about liver transplant, is done through living donors, and they do it well and safely. We are unique in North America from a liver transplant perspective that we have really the largest, both the adult and the pediatric side, the largest experience of safe living donation. And so I think pushing the boundaries. We talked about blood group matching. When kids, actually, you don't necessarily have to blood group match. We have excellent outcomes with what we would say ABO incompatible liver transplants with kids under 2 years of age. We know that worldwide. Expanding indications from cancer perspectives. And I know Gonzalo is very interested in the adult side. And so really, I think starting to push the envelope because from a pediatric perspective, our perspective is we shouldn't have any children dying on the waiting list. We should be able to find organs for all of them. And living donation here in an aggressive center like we are, and with the experience that we've had, we should be able to continue to expand those indications and our usage.
Now, Catherine, transplant recipients have to take anti-rejection drugs, usually for life. Is that something, looking forward, can we take that out of the equation? Is that something we can solve? Because that's pretty onerous for people.
Yeah, probably not by next Wednesday. So I think maybe the Wednesday after. No, just kidding. So you're absolutely right. I think, we know that we have to modulate the immune system. We don't have a way right now to make the organs less immunogenic, although there's actually active research here at UHN going on, looking at that type of work as well. we certainly use a lot less now than we even did 10 or 15 years ago. There's new drugs that potentially come to market. There's new ways of combining them. But the hope is that eventually we will find a way to really modify either the immune response or the organ to either significantly reduce or eliminate those drugs. It's not the immediate future, but it's always the goal that we're striving for.
And Atul, I want to ask you the next step of that question. Can we take people out of the equation altogether? Can we grow organs in labs? Can we use animal organs safely? Can we get people out of the equation so there are no more waits?
Yeah, I mean, that's our ultimate goal. And actually our program is heavily invested in looking at those kinds of innovations. So either, modifying organs outside the body, repairing organs outside the body, eventually being able to use animal organs, that's referred to as xenotransplantation. And then ultimately looking at stem cells just to build organs that are precisely matched to recipients. That's the future. I mean, 50 years from now, we're not going to be doing what we're doing currently. It's going to be completely different. And we're going to see a convergence of all these exciting technologies really transforming like every aspect of medicine. And I think transplantation is kind of well situated to be right at the center of that.
Yeah, and in 50 years, transplantation, the improvements have been dramatic, and they'll be even more dramatic in 50 more years.
Yeah.
So I want to wrap up. I always like to wrap up a panel with something positive. So I want to ask each of you quickly to tell me you've all worked in living donation. I want to ask you, just give me a moment or a thought of what you're most proud of in the living donation field to leave people with some inspiration. So this time I'll start with you, Gonzalo, up in the top corner.
Yeah, just very briefly, we had one of our patients now a year and a half ago. He had a massive, very young guy in his 18s, and he was deemed. We tried to resect his tumor, and it was impossible. And he had a public appeal, as we talked about, and we transplanted with this massive tumor, doing a very big operation with a very, very grateful donor that was able to donate part of the liver. And he's a year and a half out. He had no options, and he's doing amazing. So I always think about him as a good case for living donation.
Wow, that's very inspiring. Sunita?
I think, one of the things I think about every day is what a privilege it is to work with these people. My clinic is filled with people who want to help so much, whether it be their family members or just a complete stranger. It's an absolute privilege to work with these people. They are incredible. Everybody has their own kind of path of how they got there. One donor had a child through egg donation, and it was her way of kind of paying it forward. She got a greatest gift of a child through egg donation, and so donation was in her, and that was something that I will never forget.
Wow. Now, Blaine, it's always inspiring to work with children. I'm sure you have something to share.
Yeah, actually, I just got an email on Monday from a parent of one of the children we've transplanted in the last year. His child had a unresectable liver cancer, and dad was being worked up to be a donor, but was still quite big because his son was very small. We were fortunate enough to get a deceased donor for his son, and he's done very well. And so we sent him emails, said Happy Monday, and had a picture of his child. And as he's growing up, he's walking, and it looks great. But dad said in the text that my wife and I have been talking a lot, and I want to step forward to be an anonymous donor because I'm so grateful in this process. And so you really see the impact that this has on people's lives and how they want to pay it forward. And it's just always inspiring.
Nazia?
Sorry, I was muted. I think that the figure that comes to my mind now is the young kids, and particularly one story of a 16, almost 17-year-old child who wants to donate to their parents. And as a parent, I always think I am so proud of seeing a 17-year-old coming forward, and I wish my kids would love me to the same way that they would be able to come at this age forward to give me part of their liver. It's not trivial for a 17-year-old.
I'd be happy if my kids cleaned their room. I couldn't imagine them giving me their liver, but great story. Jason?
For me, I wear two hats. I'm a urologist as well as a kidney transplant surgeon. And, kidney transplantation is truly the the joyful part of my practice. Not that I am not joyful about being a urologist, but the stories that you encounter in transplantation are just wonderful. One little anecdote: I was involved with this loving husband and wife who donated. One donated to the other, and the recipient was quite sick and was a big sports fan. And every year on the anniversary of their donation and kidney transplant, they tweet me a picture of whatever they're doing. And I think last year they were at the Raptors playoff championship run. And they sort of just tweeted out about, how a year ago they were sick and in the hospital, and now they're at the Raptors game. I don't think I'm, exposing anyone because it is out in social media. But, whenever I see that every year, it's sort of very touching. It brings me back to their story. And there's lots of stories like that, but that's one particular couple that really touches me every time I hear their story.
Yeah, people do have these rituals to mark this life-changing event of transplant. They're always fascinating stories. Atul, you must have many stories. Is there one that stands out?
Well, I'll take a different tact a little bit. I mean, there's so many amazing stories out there, but I just, I also feel like I'm very proud of the colleagues that I work with. I mean, I think they're brilliant. They're pushing the boundaries, but you can see just from what the comments people have made is that really their heart is in this, and they're doing this for their patients. And that's what stands out for me, is I just feel very privileged to be able to work with such talented people here in our program.
Not only is their heart in it, but their kidney and their liver as well.
Yeah.
So Catherine, we'll give you the last word. Very inspiring comments. We'll give you the last word.
So I'm going to take a slightly different tack as well. I'm really proud of Canada, and hear me out. Transplantation can often be seen as a very local initiative where we're focusing on our donors, our surgeons, our recipients. But one of the big successes in living donation in Canada is the way that the country has come together, provincial ministries of health, ODOs, groups of surgeons, groups of physicians, coordinators, donors, and recipients who are willing to travel between provinces to facilitate living donation through things like the kidney pair donation program. We have gotten rid of interprovincial silos. We have gotten rid of interprogrammatic competition and really focused on what's important here. And in the context of living donation, we look at Canada as our village. And I am super proud to be a part of that.
So people matter, but the system matters to make it possible for people to get help.
Yeah.
Great. Well, I want to thank each and every one of you for your insight, for sharing your stories, for taking time away from your really important work to share your knowledge. So, and thank you to all our viewers for tuning in, and enjoy the rest of the conference.
Hi, my name is Christina Howard, and I'm a journalist with City TV in Toronto. And last year, I became the recipient of a living donor organ donation. My cousin Christine, quite frankly, saved my life by giving a part of her to save me. I no longer have to spend 10 hours a night, every single night, on a peritoneal dialysis machine, and my quality of life is phenomenal. I feel younger than I have in years, and it's all because of her and the fabulous team at the University Health Network. The surgeons, the doctors, the nurses, the healthcare professionals, and the administrators, every single person that touched my file there had a major role to play in making me not only have a good life, but an actual life. I am so excited to be asked to be one of the judges for this year's Innovation in Living Donation Care Research and Education Dragon's Den style panel. I can't wait to hear what all of the panelists have to offer. Their ideas could quite literally transform the lives of thousands of people all across the country. And I think it's so important to hear what some of these individuals have to say just in order to help create greater awareness. Now you can join me and listen in and be part of this online seminar. It happens on September 18th. And if you want to find out more details about the event, well, just head online.
Hi there, my name is Len. I'm a non-directed living liver donor. I'd like to tell you a little bit about the letters that I exchanged with my recipient's family after the surgery. Now, let me start by saying that as a non-directed donor, it's really important that I maintain my anonymity. In the letters that we exchange, we're not allowed to write anything that will identify ourselves to one another. So for that reason, I can't read my letters, as much as I'd love to do that, since my recipient might be watching this, so I'll speak in general terms. I started thinking about what I wanted to say in my letter to my recipient long before I sent it, long before the surgery even. It's really difficult to put thoughts and emotions into words, and I wrote and I rewrote that letter over and over, trying to get it to convey exactly what I wanted to say. The day after surgery, I had a visit from the recipient's surgeon with the amazing news that my little liver buddy was doing incredibly well. And that moment was the highlight of the whole event. It's like that moment it became real. There was actually a little person at the other end of this rope, and that added to the emotions even more, making that letter even harder to write. I finally got it down though. It's hard to explain all that I wrote in a few words here now, but I wished them well, of course, and I explained that I was doing well so they wouldn't have to worry about me. And then I said a bit about my values and my motivations for doing this. And I sent the letter a little while after the surgery. You never know if you'll receive a reply, and for some transplant donors and recipients that I've talked to, the wait can be pretty difficult. But I did receive a reply back from the recipient family a little while later. I got an email from Chantel, my transplant coordinator, saying she had a letter for me. Now, I can tell you, it was all I could do to stop myself from jumping in the car and driving straight down to Toronto General to get that letter. I had a follow-up appointment in a few days, so I cooled my heels, as they say, and I picked it up then. I opened it on the spot, and I held back the emotions as I read it. It was the best news possible. My recipient saw remarkable improvements and was doing really well. As great as it was to hear from the surgeon the day after surgery, this was obviously way better. I have both my letter and the recipient's letter here in a double-sided frame that I keep on my desk. And I read their letter every now and then, especially when I need a little boost. It still pulls out those emotions every time. So what would you say in your letter? It's obviously very personal, and everyone will have their own story with something different to say. Thank you for listening to my story, and thank you to everyone that allowed me to do my little part in what's been a life-changing event for me, and hopefully for my little liver buddy too.